from the American Academy of Pediatrics.
In the last 10 years, cases of congenital syphilis have increased by 740%.
How can we approach families with respect as we talk about difficult diagnoses?
What's most important is to try to use non-judgmental language and try to avoid phrases that put the blame or shame on a family for the situation that they're in.
But first, it's April, and that means it's time for a new First Up.
Vaccinating people during pregnancy for COVID-19 has already been proven effective in preventing infection in both the mother and the baby. And I think the results of this study can help us reassure families and ourselves that it's also safe.
These stories and more on Pediatrics on Call, the podcast on children's health from the AAP. I'm Dr. David Hill.
And I'm Dr. Joanna Parga-Belinkie. This podcast is for everyone in the medical community keeping our children healthy and safe.
It's a show by pediatricians for pediatricians.
But anyone who cares about kids will get a lot out of it as well. Let's start today's episode with the April edition of First Up.
Joanna, as young as your children are, do you ever feel compelled to tell them how their childhood compares to yours?
I mean, in my head, I'm comparing them. I'm thinking of things my parents did that I want to do better, and I'm trying to do better.
Well, I gotta confess, in my own experience, the older they get, the more tempted I am to force comparisons. And then, like you, I think back to my own parents.
Which has to be loaded for you because your dad is a pediatrician, so those comparisons have added meaning. And I wonder what it's like to have those intergenerational pediatrics discussions.
Well, it's April, which means it's time for a research roundup for the journal Pediatrics. And the associate editor of digital media, Dr. Rachel Moon, has two very accomplished daughters, one of whom is in pediatrics training. So let's start our segment with some parenting advice. Anything, Rachel, are you tempted to tell your daughter how her life as a pediatric trainee differs from yours?
Hi, everybody. So, David, are you asking about, do I ever say, when I was a resident?
Yeah, that's where I'm going with that.
Well, it's interesting because there is so much that has changed, and I think it's all for the better. So for instance, we no longer give kids sub-Q epinephrine for their asthma and then follow that by theophylline drip, which is what I did as a resident, which totally dates me. So there are things like that. But in general, actually, I think almost all of it is positive change that, as we learn more, we're doing better.
Well, I remember carrying tubes of CSF to the lab uphill in the snow both ways. So hopefully they have elevators now.
Oh, well, I had to do LPs barefoot.
Wow, guys, I'm glad I trained after you.
Yes, you are.
Yeah, it's a very different world now in medicine. I think that's a good thing.
Yeah, no, it is very much a good thing.
Well, things keep developing and changing, and that is why we've got you here today, Dr. Moon. And I got to tell you, first off, as a hospitalist making decisions about febrile infants when I'm on call, diagnosing urinary tract infections is a big part of my job. But you and I may be among the last generation of pediatricians who can read their own spun urine slides under the microscope. Are pediatric trainees these days missing out on a critical diagnostic skill that we share?
So I think what you're talking about, David, is about, can we use the dipstick or do we need to look at it under the microscope? And there's this really interesting study this month by Dr. Catherine Hunt from Boston Children's University and colleagues from around the country entitled Urine Dipstick for the Diagnosis of Urinary Tract Infection in Febrile Infants 2 to 6 months old. So this is always a question that comes up. Should you send it to the lab? Should you just rely on the urine dipstick? Because urine dipstick is so much easier and it's cheaper and is more accessible. But we also do know that infants, they often cannot yet concentrate their urine. So that could affect the accuracy of these tests. So Dr. Hunt and colleagues looked at the accuracy of urine dipstick versus urine microscopy for these young infants. And so they conducted a secondary analysis of retrospective cross-sectional data from 5 pediatric medical centers. All of the infants were 2 to 6 months old. They had all presented to the emergency department for a fever. They all had a fever documented during their emergency department visit, and they had a urine culture collected. They did exclude infants who had complex medical histories, including urogenital abnormalities. And then they compared the test characteristics of urine dipstick and urine microscopy in detecting UTI for those who had a urine culture with at least 50,000 colony-forming units of a single bacterial pathogen. So they looked at sensitivity, specificity, negative predictive value, and positive predictive value. They also used receiver-operator characteristic curve analysis to determine the optimal urine microscopy cutoff for white blood cells that you needed to detect UTI. So what they found was that the optimal cutoff point for urine microscopy was when there was at least 7 white blood cells per high-powered field. And then when they used this cutoff, they found that urine dipstick actually had a higher sensitivity and specificity than microscopy, so 90 to 93% versus 84 to 87%. And then urine dipstick also had a better predictive value than microscopy, and that these findings persisted at a urine culture cutoff of greater than 10,000 colony-forming units per mil. So one of the caveats here is that the authors could only analyze samples that had a urine culture sent, which may inflate sensitivity, as we usually don't get a culture if the initial urine sample doesn't look infectious. But the high negative predictive value, which is not affected by the prevalence of the disease, indicates that we can likely rest easy not prescribing antibiotics if you have a negative dipstick in this age group. So overall, I think that this study provides a strong argument for the utility of urine dipstick as a diagnostic test for UTI in this young age group, which is great news for primary care doctors and emergency department clinicians.
And I think would also be useful in the NICU, where we run urine studies as well. And another big part of my job is actually taking care of newborns with major structural birth defects. And we know that COVID-19 infections can complicate pregnancies. But what about COVID vaccination? Is there any reason to be concerned that the world's first mRNA vaccine might contribute to birth defects when given to pregnant women?
That is a great question, Joanna. And even though we would all like to think that SARS-CoV-2 or COVID-19 has gone away, we still see it, not uncommonly, and we all encourage a vaccination against this virus. One group, as you mentioned, that's at particular risk for complications from COVID-19 infection are those who are pregnant, and these complications can also impact the infant. So that's why we have been recommending COVID-19 vaccination during pregnancy since 2021, August of 2021, because it helps to protect both the pregnant mother and the infant. But I think that all of us are probably often asked about the safety of the vaccine during pregnancy. And we particularly worry about safety during the first trimester, since that's when you can get those serious teratogenic effects. So this month we have an article by Dr. Stacy Rowe from the University of California, San Francisco and colleagues entitled COVID-19 Vaccination During Pregnancy and Major Structural Birth Defects. The authors compared the prevalence of major structural birth defects based on when during pregnancy the vaccine was given, so during early pregnancy versus later or not at all. And they used 2 large insurance claims-based databases, which provided information on vaccination status and timing, maternal comorbidities, and sociodemographic factors for both privately and publicly insured women. They looked at more than 78,000 pregnancies between August 2021 and September 2022. 16% of the cohort, so almost 13,000 women, received COVID-19 vaccination between 14 days before their last menstrual period and 20 weeks of gestation, which is considered the time frame with the highest risk for any potential teratogenic effects. So they found that there was no increased risk of preterm birth. The median birth gestational age was 38 weeks for all of the people in the study. There was no difference in the prevalence of major structural birth defects. And this remained true even after they considered who was the insurer, the vaccine brand, if they had had a COVID infection during pregnancy, or if they had gotten any other vaccines. So I think this is really great news. We already know that vaccinating people during pregnancy for COVID-19 has already been proven effective in preventing infection in both the mother and the baby. And I think the results of this study can help us reassure families and ourselves that it's also safe even early in pregnancy.
Well, I am thrilled to hear that because the early days of the COVID pandemic are days of medical history I do not ever want to repeat.
I'm with you there.
I know. But keeping it in the topic of medical history, generations of pediatricians before us observed that social settings drive health outcomes, which is why Dr. Abraham Jacoby, the founder of the AAP, envisioned pediatricians from the beginning as advocates far beyond the exam room. But even with the burgeoning research on social drivers of health, finding a consistent measure for those has proved challenging. Do we now have reliable research tools to help us tie where children live to the social drivers of their health, and why would it matter if we did?
Yes. So I want to talk about the Child Opportunity Index. And this is a composite measure of the resources and opportunities that are available to children in their neighborhoods. And this includes factors like education, health, socioeconomic conditions. And so this month, we have an article by Jordan Tyrus, MD, and colleagues at Children's National Hospital and Eunice Kennedy Shriver National Institute of Child Health and Human Development, in which they performed a meta-analysis to look at associations between the Child Opportunity Index, or the COI, and pediatric health. And they found that if there was a lower COI, which means that the neighborhood was less resourced, had fewer resources, that was associated with adverse health outcomes across multiple areas of child health, including physical health, mental health, and access to care. They found that a lower COI was associated with increased all-cause emergency department utilization, increased hospital readmissions more than 30 days out, and importantly, 50% higher child mortality. So this article strongly suggests that it's location, location, location. So family-based interventions are sometimes not enough. We have to move towards community-based strategies that address the root causes of all of these disparities. We also asked Dr. Michael Warren of the Health Resources and Services Administration and Dr. Morgan McDonald of the Milbank Memorial Fund to write a commentary on this article, and they talk about the pediatrician's role in this. So they encourage all of us to move beyond the bedside and engage with community partners to address social needs, to advocate for policy changes that will strengthen community resources, and to participate in community and public health programs like Healthy Start, WIC, SNAP, and home visiting programs. So I think that both of these articles are important, and I would encourage our listeners to read them both to learn about the many ways that the neighborhood can affect a child's health and what we can do to help address the social needs in our communities.
This is so important for pediatricians to read. And Rachel, it's now the springtime. Hopefully people are getting outside more in their communities. Are you planning on any spring break trips?
No, not any spring break trips this year. I think we're going to be waiting until summer. But it is very nice to have spring and to not have to wear 15 jackets when we go outside and not to have to walk over melting snowbanks. And I'm loving seeing all of the blossoms and the flowers and the pollen. Everything came out at once in Virginia, and so we've got a lot of pollen.
A lot
Here
of
in our neighborhood
allergies.
in North Carolina, we had a big pollen fight. We made pollen balls. And
Oh, do you?
threw them
Oh,
at each other
that's a
and-
good tradition.
I feel like everybody knows about the cherry blossoms in DC, but actually Philly has some pretty awesome cherry blossoms. So if anyone has the opportunity to make it to the city, when hopefully by the time they're listening to this, they were still around. It's very worthwhile and probably less touristy than DC.
Yeah. Well, I'm sure that in Philly, it probably follows DC by a couple of weeks. So, and in DC, I think that they've already kind of peaked and waned. So everybody rush up to Philly.
Come on up. We welcome you. To read the articles we discussed today, go to aap.org/podcast.
Coming up, we'll discuss how to navigate difficult conversations with families after a diagnosis of congenital syphilis. Joanna, do you remember the fascinating conversation we had backstage at the National Conference and Exhibition with Dr. William Golden before he gave his plenary address on congenital syphilis?
I do. Syphilis has become more of an issue in neonatology, and I was so glad it took center stage in Orlando. There's always more to learn about congenital infections, particularly in my field.
Oh, seriously, full confession. It was the first time I really understood why both my hospitals use the reverse sequence syphilis screening protocol, but I still have to turn to the Red Book's new syphilis algorithm every time I get an abnormal result.
And that's before you walk in and talk to the family. For me, that's often the hardest part of working through this diagnosis. There's not only alarming news to share, but stigma, equity issues, and medical privacy to think about.
Whew, that is a lot. Fortunately, today we have an opportunity to learn more, not only about congenital syphilis, but also about how we can have those sensitive conversations with families. We'll hear from Drs. Adam Ratner and Nitya Shah.
Dr. Ratner is a professor in the Department of Pediatrics and Microbiology and director of the Division of Pediatric Infectious Diseases at the NYU Grossman School of Medicine, Hassenfeld Children's Hospital, and Bellevue Hospital Center. He is also the author of Booster Shots, The Urgent Lessons of Measles and the Uncertain Future of Children's Health.
Dr. Shah is an assistant professor in the Division of Neonatology and Division of Palliative Care at Emory University School of Medicine. She practices neonatology and palliative care medicine at Children's Healthcare of Atlanta. Adam, Nitya, welcome.
Thank you for having us.
Great to be here.
Adam, I'd love to start with you. Congenital syphilis is a lot more common than it used to be. What are the numbers?
Yeah, it really has been an alarming rise over the past decade or so. So in 2012, there were about 330 cases of congenital syphilis in the United States, and that went up to over 3,000 in 2022, almost 4,000. We were at 37-something was the final number for that year. There was another increase in the year after that for the 2023 data, but it was a smaller one. So there's some hope that this is leveling off, but it is still going up.
And do we know what factors are contributing to these trends?
Yeah, as with many things, this is multifactorial. I mean, one of the major things is that there's simply more syphilis, and there's more syphilis in the age group of people who are having children, and that's the major driver. And the other piece of it is, as you know, as anyone who works with mothers and children knows, we screen for syphilis, and it is a complicated process with multiple instances of screening during pregnancy. And that's a system that works well, but it also relies on people to adhere to the algorithm, to act on a positive test, and it requires a good functioning public health system and a system where you can act on those positives.
And Adam, I know the range of presentations for syphilis can go from asymptomatic to quite severe. Do you mind reviewing what we might see in affected newborns?
Absolutely. So at the most severe end of the range, syphilis can cause miscarriage, it can cause stillbirth, and the most recent year of reporting, I think there were about 250 stillbirths known to be linked to congenital syphilis in the U.S. There are probably others where that was undiagnosed. At the other end of the range, as you mentioned, there are children who are born with congenital syphilis who have no symptoms at all, who may be diagnosed because we do screen in pregnancy, and then we screen newborns when we know that they are exposed, and then they test positive, but they have nothing on physical exam to speak of. And then there is a range between that where you can get any one of a number of findings. Often the only thing that you find is some hepatosplenomegaly. Some children will have snuffles, which is copious nasal discharge. Some kids, the major presentation is just some adenopathy. On x-rays, you sometimes see periostitis or osteochondritis. Some kids have the classic rash of syphilis that people talk about is sort of a dark red, almost copper-colored rash that can involve the palms and the soles. And there are some laboratory findings that go along with it. We sometimes see hemolytic anemia. We sometimes see thrombocytopenia. So those are a piece of the list of things that you can see with congenital syphilis.
And you were talking about screening just a moment ago. Can you kind of run us through how we should be screening in pregnancy and what testing we're doing in these pregnant mothers?
Right. So everyone who is pregnant should be screened during pregnancy. And ideally, in an area where there is a fair amount of congenital syphilis, and that is most of the United States now, people get screened at 3 points during pregnancy. So often it's in early pregnancy, at the beginning of the third trimester, and then again right around the time of birth. That isn't true everywhere. Some states and local public health departments have different rules, and it depends to some extent on the prevalence of syphilis and the risk factors of the person. But the screening 3 times approach is a very common one in the United States.
And Adam, I admit I have spent more than a little time staring at tables 3.18 and 3.72 in the syphilis chapter of the Red Book. Can you break...
You and me both.
Thank you. Can you break down the principles behind treating congenital syphilis?
Yeah, absolutely. So there is the algorithm in the Red Book that I still look at every single time, just like you do, because it is complicated and I want to make sure that I get it right, because what it allows us to do is go from the point of screening in pregnancy through, laboratory values in pregnancy, the findings in the infant, and you end up with a categorization of the infant into, anything from congenital syphilis unlikely, which is the sort of the best category. It's not something that can be completely ruled out by anything on the algorithm. Congenital syphilis less likely, possible congenital syphilis, and then proven or highly probable congenital syphilis. And then each of those categories has a different workup that's associated with it and a different suggested treatment that's associated with it. And it is worth for any child, I think, who has an abnormal testing, anyone who you suspect of having congenital syphilis, of really just walking your way through that algorithm, because there is overlap in what you might see between the different categories, and it's important to get it right.
And what sorts of outcomes can we expect from treatment if we're doing it right?
So to some extent, that depends on how the child is presenting. So for kids with minimal symptoms or no symptoms at all, who are identified around the time of birth and who are treated with penicillin, the outcomes are very good. And they still need monitoring over time and to have a good relationship with the pediatrician and be able to be followed longitudinally. But the outcomes are generally good in those cases. Kids who present with more severe disease, kids who present with central nervous system disease early on, the outcomes are much more concerning in those cases.
And Nitya, just hearing that a newborn might have congenital syphilis can be so emotional for parents. How would you recommend we start this discussion with the family?
Yeah, absolutely. I think all of these topics are incredibly sensitive and intimate, and you're getting into people's private histories. And so I think what's most important is to try to use non-judgmental language and try to avoid phrases that put the blame or shame on a family for the situation that they're in. And I think having genuine curiosity about their circumstances and how we can be helpful can really shine through in those types of conversations.
And if the father or partner is unaware of the infant's syphilis diagnosis, how do you go about protecting the privacy of the birth mother?
That's a great question. I think we are very good in these situations oftentimes about trying to decipher that before we go into a room. And so you're not disclosing someone's private information to family members. And that's something that we should be doing sort of across the board for many different situations, but particularly for things like sexually transmitted diseases like syphilis or HIV.
And it seems like so many things in what we do come down to communication. Are some people just better at communicating with families than others? And if we do need to be better, Nitya, how can we tell? And then what can we do?
That is a great question. I think that one of the misconceptions about communication in medicine is that it is something that people are born with or something that they just learn the art of by watching other people. But the reality is that these skills are trainable and learnable. And if you find the right resources and put the time and effort into it and really practice and hone those skills, it's possible to be good at communication in a variety of situations where it's needed.
Are there particular resources that you turn to when you're teaching or mentoring?
I use many different resources, such as acronyms that we use, sort of like procedural skills, in the same way that we might learn how to do an intubation and the steps that it takes for that. There are several acronyms that can be used, or national programs like Vital Talk that can be helpful to learn some tips and tricks and have an arsenal of tools to pick on when you're meeting with a family and delivering serious news or responding to emotion within those conversations.
So again, when we're having these what can be kind of difficult discussions with families, how do we make sure that our own biases in the diagnosis aren't showing through? Nitya, do you have any tips on that?
Yeah, I think a big piece of that is actually work that we have to do not right before we walk into the room, but on sort of a continuous timeline of always reflecting on how we view these situations and the implicit and explicit biases we may apply to these situations. Because if we don't have the insight into that, it is surely going to come out in the words we use or the way we interact with folks. So I think taking the time to understand ourselves is incredibly important and not a small task.
And when making this diagnosis, Adam, are there challenges in how we make it?
I think that when we think about diagnosis of congenital syphilis, one of the things that we focus on is missed opportunities, because it is something that is preventable if you can diagnose syphilis during pregnancy and if you can provide treatment during pregnancy. So looking back on the 2023 cases, more than 40% of them had no documented test at an appropriate time during pregnancy, and almost a quarter of them had no documented treatment at all. And those are people who tested positive. So we have a lot of work to do just in terms of improving quality across diagnosis of congenital syphilis.
We love our guests to leave listeners with one takeaway they can use. Adam, can you start with one about congenital syphilis?
Congenital syphilis is very common. It's more common than it is when many of us trained, and it's something that you can diagnose if you think about it, and it requires some effort, but it's important. And the other thing is that, as we touched on earlier, what you do with a positive test can be nuanced, and there is no shame in going to the Red Book and taking yourself through that algorithm, as I do every time.
And Nitya, do you have any on best communication practices for difficult diagnoses in general?
I think my biggest takeaway would be to try and remember that everyone deserves grace on your hardest days and when you're receiving difficult news or diagnoses, and that empathy can go a really long way when a family is facing uncertainty or fears about the future for their child.
Well, Doctors Nitya Shah and Adam Ratner, thank you so much for joining us today.
My pleasure. Thanks.
Yes, thank you for having us.
To learn more about congenital syphilis and having difficult conversations with families, go to aap.org/podcast.
At the end of every episode, we like to leave you with something positive or enlightening. We call this segment Say Ah. David, what's your Say Ah this week?
So we just had the week here in Wilmington where the wisteria blooms, and it's a small thing, but it's like the whole town just got decorated for spring. The periwinkle blue of these flower clusters just hanging out everywhere just brings me so much joy. If you get stuck in traffic and you're looking at wisteria, you just don't want it to keep moving again. At least that's me. So that's just my little moment of enjoyment.
I say, maybe more enlightening than very positive, but my baby Zelda is going through a sleep regression. And it's because you could just tell that her brain is turning on and she understands that we have left the room to put her to bed. And she is no, I want you to stay and hold me. And the reason why I'm mentioning this as as tired as I am, is it's my last baby and I don't plan on having any more. And she just cuddles right in. And so I am just having the toughest time with her sleep hygiene because all I want to do is hold her. But luckily I have a partner who's trying to support me in putting her back to sleep. But it's one of those crazy things of parenting. Well, yes, I'm very tired and I want to sleep, but it is also so nice to cuddle your baby, especially when they want you,
I get that. But you guys have a strong partnership, so it's all good. That's it for today's episode. If you like Pediatrics on Call, please subscribe on your favorite podcast app and help us spread the word. Follow us on YouTube, Facebook, and Instagram at Pediatrics on Call.
Pediatrics on Call is a production of the American Academy of Pediatrics. Our producers and editors are Ann Johnsos and Claire Keating. Our audio engineer is Doug Nagel. Joe Puskars is our associate producer, and Susan Martin is our executive producer. Our theme music was composed by Matthew Simonson. Join us next week when we'll focus on how and when to disclose adverse events in pediatrics.
We'll talk to the author of a new policy statement, Dr. Laura Sigmund. I'm Dr. David Hill.
And I'm Dr. Joanna Parga-Belinkie. Thanks for listening.